Welcome back to the deep dive. Today we are metaphorically scrubbing up, donning the sterile gowns, and walking into the operating theater.
We are.
We're tackling a subject that is physically long, anatomically, well, winding, and clinically, let's be honest, a bit of a minefield.
It's a significant one. I mean, in the world of general surgery, this topic is often referred to as the dark continent of the abdomen.
The dark continent, why is that?
Because it's vast, it's mobile, and when things go wrong, they can go wrong in very complex ways.
We are focusing specifically on Chapter 74 of the 28th edition of Baily and Love's Short Practice of Surgery. The subject is the small intestine. Now, looking at the stack of notes in the textbook you brought along, this is dense material. So before we grab the scalpel, we need to set the ground rules. What exactly is our mission here today?
I think our mission is revision and interpretation.
Okay.
This deep dive is designed for the medical student, the surgical trainee who's preparing for exams, or even, the practicing clinician who just needs a refresher. We're going to take the incredibly dense text of Chapter 74 and turn it into a ready reckoner.
Exactly. We are interpreting the text to make it digestible. I want to be really clear on this. This is not a regurgitation.
No.
We aren't just reading the book to you verbatim. That would be, I think, the world's most boring audiobook.
It absolutely would. Please, do not use this conversation as your only source.
Yes.
You absolutely must read the fine print in the actual textbook. Consider this conversation the framework, the skeleton, if you will, upon which you hang all the specific details you get from reading the chapter yourself.
Right.
The mantra for today is, you interpret, you understand, you remember. That's the goal.
They promise to keep it engaging. We've got metaphors, we've got memory anchors, and we've got some fictional case studies later on to see if you're paying attention. We want this to feel like a conversation in the break room, not a lecture in a hall.
And we have a lot of ground to cover. We're going to map the geography of the bowel, move through a rogues gallery of infections, examine some very specific tumors, deal with vascular catastrophes, and end with the complex plumbing of stomas and fistulae.
So let's start with the lay of the land. Section 1, anatomy and physiology. When a surgeon opens the abdomen and sees this mass of pink tubular loops, it looks chaotic.
It does.
But Baily and Love gives us very specific boundaries. Where does the small intestine technically begin and end?
So technically, we define the small intestine as starting from the pylorus of the stomach and ending at the ileocecal valve.
Okay.
However, the duodenum, that first part, is retroperitoneal. And it has such a unique set of pathologies that it's usually treated as a separate entity.
Ah, I see.
So for the purpose of Chapter 74, we are focusing on the jejunum and the ileum.
So the road trip starts at the duodenojejunal flexure, the DJ flexure, and ends where the small bowel dumps into the colon.
Correct. That's our territory for today.
And how long is this road trip? I was looking at the numbers in the text, and frankly, I was a bit confused by the variance.
That is the million-dollar question, isn't it? It varies wildly. The text mentions studies showing a range anywhere between, 300 and 850 centimeters.
That is a massive margin of error. I mean, that's a difference of over 5 meters. Why is it so hard to pin down?
Well, it all comes down to muscle tone.
Okay.
The small bowel is a muscular tube. And a living person, that tone shortens it. It kind of scrunches it up.
Right.
But in a cadaver, or when the muscle relaxes completely under anesthesia or after death, it elongates significantly.
So it just stretches out.
It stretches out. So the measurement depends entirely on whether the subject is alive or dead, which, clinically speaking, is a fairly important variable.
Fair point. So for a mental map, let's just agree it's long, winding, and packed into the abdomen. Now let's play a game of spot the difference. We have the jejunum and the ileum. The book says there's no sharp line dividing them. I can't just put a flag in the ground and say, welcome to the ileum.
No, absolutely not. It's a gradual transition. But the extremes, the proximal jejunum right at the start and the distal ileum right at the end, they look and feel very different.
So help us visualize this. I like to use the metaphor of the jejunum as the muscle man of the operation.
That's a very good anchor.
Yeah.
I like that. The jejunum makes up roughly the proximal 40% of the bowel.
Right.
It has a wider diameter and a significantly thicker wall. And if you were to cut it open and look inside, the mucosal folds, they're called the valvulae conniventes, are very, very prominent.
So it's rugged inside.
Very rugged, like ridges in a mountain range. The other thing is the blood supply. The arteries form simple, long arcades, so you can see right through the mesentery. It's quite translucent.
And that's because it's doing the heavy lifting, all that muscle and surface area.
Precisely. In terms of physiology, the jejunum is the principal site for digestion and absorption. It absorbs fluid, electrolytes, iron, folate, fat, protein, carbohydrates, you name it.
The workhorse.
It is the workhorse. It needs that surface area, those rugged folds, and that muscular wall to drive the process.
Okay, so if the jejunum is the muscle man, how do we characterize the ileum?
So the ileum is the distal 60%. And if the jejunum is the muscle man, you might call the ileum the fatty storehouse.
The fatty storehouse. Why is that?
Well, the bowel wall itself is thinner and narrower than the jejunum, but the mesentery, that's the tissue attaching the bowel to the back wall of the abdomen, is much, much thicker, and it's packed with fat.
Ah, so it's opaque.
It's completely opaque. You can't see the blood vessels through it as easily as you can in the jejunum. And speaking of vessels, the arterial arcades in the ileum are much more complex, lots of little tiers of arches.
And it has a specific feature that the jejunum doesn't, right? Something involving the immune system.
Yes, this is a key difference. Peyer's patches.
Peyer's patches.
These are large aggregates of lymph nodes that are embedded right in the wall of the ileum. They are crucial for immunity, constantly sampling the gut contents for bugs.
But, as with many things in medicine, they have a dark side, a potential downside.
They do. In children specifically, these Peyer's patches can become inflamed, they can swell up, and they can act as lead points.
A lead point, what does that mean?
Imagine the bowel wall, the peristalsis, grabbing onto this swollen lump of lymphoid tissue and pulling it forward. It basically telescopes the bowel into itself.
And that's intussusception.
That's intussusception, exactly. So the anatomy directly predicts the pathology. It's a classic example.
That's a great clinical hook. So jejunum is thick, muscular, rugged inside. Ileum is fatty on the outside, thinner wall, with Peyer's patches.
In a nutshell, yes.
Now, regarding physiology, you mentioned the jejunum does the heavy lifting for most nutrients. But the ileum has a superpower, doesn't it? It's a specialist.
It is. And this is probably one of the most critical facts for a surgeon to remember. The terminal ileum is the only place in the gut that absorbs two very specific things: bile salts and vitamin B12.
The only place. So this is the so what factor. Why does this matter so much to a surgeon who's planning an operation?
It matters immensely for resection. If you lose a large chunk of your jejunum due to, say, injury or disease, the ileum is smart. It can adapt.
Okay.
It can upregulate its absorption and over time take over the job. But if you lose the terminal ileum, the jejunum cannot learn to absorb D12 or bile salts. That machinery simply doesn't exist upstream.
So the patient is left with permanent deficits? There's no backup plan?
No backup plan, yes. If you lose the terminal ileum, you lose the ability to recycle bile salts. Those salts spill into the colon, where they act as a potent laxative, causing severe watery diarrhea. We call it choleritic diarrhea.
And a B12.
And, of course, you lose B12 absorption, leading to megaloblastic anemia and potential neurological issues down the line.
So saving the terminal ileum is always a priority, if you possibly can.
Absolutely. It is precious real estate.
All right, time for our first check-in. We want to make sure these concepts are sticking. Listener, hit pause if you need to think about this. Question 1. Which part of the bowel contains Peyer's patches? And question 2. Which part of the bowel is solely responsible for absorbing vitamin B12 and bile salts?
Think back to the muscle man versus the specialist.
Got it. It's the ileum for both. Peyer's patches are in the ileum, and the terminal ileum acts as the specialist for B12 and bile salts. If you missed that, rewind. It's foundational for what comes next.
Right, let's move on.
Let's enter the infective and inflammatory landscape. This is section 2 of our outline. We're looking at the usual suspects of infective enteritis, who is at the top of the list in the UK and many other places.
The most common cause of bacterial gastroenteritis is Campylobacter jejuni.
The poultry bug.
Yes, often acquired from infected or undercooked poultry. It's a spiral-shaped gram-negative rod. Now, usually this is just a bad tummy bug, diarrhea, malaise.
Right.
But the clinical trap here, and the reason it's in a surgery textbook, is that it causes severe abdominal pain.
Pain that mimics something else.
Pain that perfectly mimics an acute abdomen. You might have a patient with severe right-sided pain, a fever, and tenderness. A surgeon might open someone up thinking it's appendicitis or peritonitis.
And it's just bad chicken.
And it turns out to be just bad chicken.
That is a nightmare scenario. Unnecessary surgery.
It is. And it can even mimic ulcerative colitis because it sometimes causes rectal bleeding. Usually it's just supportive treatment fluids and rest, but it's a notifiable disease.
Next on the rogues gallery is Yersinia. I call this one the great mimic.
Yes. Yersinia enterocolica. This organism has a real predilection for the terminal ileum and the lymph nodes in that area. It causes something called a granulomatous inflammation.
Granulomatous implies it forms little lumps or nodules, which sounds a lot like something else we know.
It sounds and looks exactly like Crohn's disease.
Wow.
And because it makes the terminal ileum thick and boggy, and it swells the lymph nodes in the right lower quadrant, it mimics appendicitis perfectly.
So you go in for an appendectomy.
And you find a normal-looking appendix, but a thick, angry terminal ileum and these massive lymph nodes. That's the classic Yersinia presentation.
That is a classic exam scenario too, isn't it?
Absolutely. The normal appendix, but inflamed terminal ileum.
Now let's talk about a heavyweight. Salmonella and typhoid.
Right. So salmonella generally causes food poisoning, but Salmonella typhi causes typhoid fever. This is a systemic infection, not just a gut bug.
There are some very specific anchors for typhoid that Baily and Love highlights, things that act as red flags.
The first one is the rose spots.
Rose spots.
These are small pink spots that appear on the abdomen. They're actually caused by bacterial amblyal clumps of bacteria clogging small vessels and causing vasculitis.
Fascinating. And then there is the danger zone. When do things go really wrong?
The timing is crucial here. If perforation of the bowel is going to happen, it typically occurs in the 3rd week of the illness.
The 3rd week. That is incredibly specific. Why then?
It corresponds to the cycle of inflammation in the Peyer's patches. By the 3rd week, the necrotic tissue, the dead tissue, slows off. If the ulcer is deep enough, when that scab falls off, you're left with a hole.
A perforation. And the ulcer itself, there's a geometric distinction here that is a favorite for examiners.
This is critical for differentiating from tuberculosis. A typhoid ulcer runs parallel to the long axis of the gut.
So it's longitudinal.
It's longitudinal because Peyer's patches themselves are longitudinal. The ulcer forms in the patch, so it follows the shape of the patch.
Long axis for typhoid. Got it. Now contrast that with tuberculosis or TB of the intestine.
2D ulcers are transverse. They run like a bilt around the bowel circumference.
Why the difference?
It's because of how the bug spreads. TB spreads via the lymphatics, and the lymphatic vessels in the bowel wall run transversely. They follow the blood vessels. So typhoid is longitudinal, TB is transverse.
That is a gold standard revision fact right there.
Yeah.
Speaking of TB, the text mentions 2 types. What's the difference?
You have ulcerative TB and hyperplastic TB. And the difference really comes down to the patient's immune system.
Okay, explain.
Ulcerative TB usually happens when a patient has active pulmonary TB, so open TB in the lungs, and they are swallowing the bacteria. Their immunity is generally low.
Right.
The bacteria invade and just eat away at the tissue, causing these transverse ulcers.
And hyperplastic. Hyperplastic
TB occurs in people with high resistance to the organism. So they might have swallowed the bug, but their body fights back, and it fights back hard.
So it's an over-exuberant immune response.
Exactly. The battle creates a massive inflammatory response.
Yeah.
Deep fibrosis, thickening, scar tissue. It forms a mass.
So high resistance creates a mass.
Precisely. It creates a thick, fibrous mass in the ileocecal region. And clinically, it looks just like a cancer or, again, Crohn's disease.
It's a diagnostic nightmare.
It is. You often can't tell what it is until you take a biopsy or, more likely, remove it.
We briefly mentioned Crohn's disease, but the text says it's the only true inflammatory bowel disease of the small intestine. We won't dive deep because that's chapter 75.
Correct. It's the elephant in the room for small bowel inflammation, but it deserves its own deep dive.
Let's shift gears to section 3, tumors.
Okay, from the infectious to the neoplastic.
Let's start with a syndrome that has a very, very visual anchor. Peutz-Jeghers syndrome.
Ah, yes. This is one you can spot from across the room if you're observant.
Really?
Yes. If you see a patient, often young, with melanin spots, essentially freckles on their lips, inside their mouth, on the buccal mucosa, and on their fingers, you must think Peutz-Jeghers.
It's autosomal dominant. And what's happening inside the gut?
They have multiple polyps throughout the intestine, and these are specifically hamartomatous polyps.
Hamartomatous just means a disorganized overgrowth of normal tissue, right? It's not essentially a precancerous bomb like an adenoma.
That's a great way to put it, correct. The polyps themselves rarely turn malignant, however, they are big and clunky.
So they cause mechanical problems.
Exactly. Mechanical problems like obstruction, or that telescoping intussusception we talked about earlier.
But there is a cancer risk associated with this syndrome, isn't there?
Yes, and this is the trap. The risk isn't necessarily in the polyp itself. The patient has a significantly increased risk of cancer elsewhere.
Elsewhere.
Breast, cervix, pancreas, ovary, testes. The spots on the lips are a warning sign for systemic cancer risk.
So the polyps are the mechanical trouble, but the cancer risk is in other organs.
Precisely. It's a key distinction.
Okay, let's talk about the bad stuff. Malignant tumors. They are rare in the small bowel, aren't they? Compared to the colon.
Very rare, yes.
Oh.
Which is strange, given how long it is. The small bowel is surprisingly resistant to cancer. However, we do see adenocarcinoma often associated with coeliac or Crohn's.
And lymphoma.
We see lymphoma, specifically Burkitt's lymphoma in children, which loves the ileocecal region. It grows incredibly fast.
But the one that gets the most attention in exams and recent research seems to be GIST, gastrointestinal stromal tumors.
GISTs are fascinating because they really changed how we think about treating some cancers. They are mesenchymal tumors arising from the bowel wall. The key marker you need to remember, the ID card for this tumor, is c-KIT, or CD117.
CD117, why is that marker so important?
Because it gave us a target. We developed a magic bullet drug called imatinib.
Right, the tyrosine kinase inhibitor.
Exactly. It specifically turns off the signal the CD117 sends, and the tumor stops growing, or in many cases, shrinks dramatically.
So it's a surgical disease that now has a very effective medical treatment. But there's a warning in the text about shrinking them too fast.
Yes, and this is a great example of where biology meets physics. If you have a large cyst in the wall of the bowel, and you give imatinib, the tumor might shrink very rapidly. It can literally melt away.
And if it melts away?
You lose the structural integrity of the wall, you can actually cause a perforation.
Whoa.
You turn a mass into a hole in the bowel. So surgeons and oncologists have to be very careful managing large GISTs. Sometimes they'll operate first or shrink it just a little before surgery.
Now, my favorite tumor topic, purely because of the metaphor, neuroendocrine tumors, or NETs, formerly known as carcinoids.
Ah, yes. These arise from the Kolchitsky cells, which live deep in the crypts of Lieberkühn.
Great names. Kolchitsky, crypts of Lieberkühn. It sounds like something from a fantasy novel.
It does, doesn't it? These cells are part of the APU system. They produce amines and vasoactive chemicals, mainly serotonin.
Okay.
Now here is the customs officer metaphor to explain the symptoms or lack thereof.
Break it down for us.
Normally, all the blood that drains from the gut goes into the portal vein.
Right.
The portal vein goes straight to the liver. The liver is the customs officer.
It checks the cargo coming in.
Exactly.
Yes.
It contains enzymes like monoamine oxidase. It confiscates the contraband. It breaks down the serotonin before you get to the rest of the body.
So you can have a tumor in your appendix pumping out serotonin, but you have zero symptoms.
Exactly right, because the customs officer is doing his job. Unless the tumor spreads. If you have metastases in the liver, those tumor cells are sitting after the checkpoint. They dump serotonin directly into the hepatic veins, which go straight to the heart and then into the systemic circulation.
The customs officer had been bypassed. The contraband is loose.
The contraband is loose, and that's when you get carcinoid syndrome.
And what does that look like?
The serotonin hits the body. You get flushing, a classic reddish-blue cyanosis of the face. You get explosive diarrhea. You get bronchospasm, so wheezing. And eventually, it damages the right side of the heart, causing tricuspid stenosis.
And what's the trigger for a flushing attack? The text mentions something specific.
Alcohol. A glass of wine can provoke the tumor to dump a load of serotonin and set off a flushing attack. It's a classic exam question.
Fascinating. So liver mets are the key to the syndrome because they bypass the liver's filtration.
Precisely. No liver mets, no carcinoid syndrome.
Moving on to section 4. This is a staple of surgery. If you know nothing else about the small bowel, you know the rule of twos. We are talking about Meckel's diverticulum.
Let's set a scene to make this stick. We have a fictional case study.
Okay.
An 18-year-old male comes into the ER. He has pain in the right lower quadrant. He has nausea. He has a low-grade fever. You examine him, and you are 100% sure it is appendicitis.
It walks like a duck. It quacks like a duck.
Exactly. You take him to the operating theater.
Yeah.
You put the camera in.
Yeah.
And the appendix is lily white. It's perfect. It's completely more.
Panic stations. What do? You can't just close.
You absolutely do not just close up. You have a duty to check the ileum. You run the bowel looking for a Meckel's diverticulum.
What exactly is it, anatomically?
It's a congenital remnant of the vitellointestinal duct, which was the tube that connected the yolk sac to the gut in the embryo.
Right.
Usually, it disappears completely. In some people, it stays behind as a little pouch on the side of the ileum.
And to remember the details, we use the rule of twos. Let's recite them slowly. Listener, count along.
Number 1, it occurs in 2% of the population.
2%.
Number 2, it's located 2 feet or about 60 centimeters from the ileocecal valve.
2 feet.
Number 3, it is usually 2 inches long.
2 inches.
And number 4, it contains 2 types of ectopic tissue.
That last one is the kicker, isn't it? Ectopic tissue, tissue that shouldn't be there. What kind?
Usually gastric so, stomach lining, or pancreatic tissue.
And this explains the symptoms, doesn't it? If I have stomach lining in my ileum.
It behaves like stomach lining.
Yeah.
It secretes hydrochloric acid.
Ouch.
Right. But the small bowel is not designed for acid. It doesn't have the protective mucus layer that the stomach has. So the acid burns the adjacent normal bowel. It ulcerates.
And that leads to?
Painless, dark red bleeding. It's a classic cause of significant GI bleeding in a child or young adult.
What else can a Meckel's do besides bleed?
It can cause obstruction. Sometimes there is a fibrous band connecting the tip of the diverticulum to the umbilicus, the belly button.
A remnant of the old duct.
Exactly. And the bowel can twist around that band, a volvulus. Or the diverticulum itself can get inflamed, mimicking appendicitis, or it can get stuck inside a hernia.
And that has a name, too.
It does. A Litter's hernia. A Meckel's diverticulum found inside any hernia sac.
Okay, check-in number 2. Can you recite the 4 components of the rule of 2s?
Let's see. 2%, 2 feet, 2 inches, and 2 ectopic tissues.
If you got that, you're golden. If not, pause and repeat. It's high yield for exams and real life.
Right, let's move to section 5. Vascular emergencies. This is serious, serious business.
Mesenteric ischemia. Essentially, a heart attack of the gut. What is the biggest clinical red flag that Baily and Love screams at us to remember?
The phrase is, pain out of proportion to physical findings.
Elaborate on that. Paint the picture for us.
So, you have a patient, often elderly, who looks terrified. They are in severe agonizing pain, maybe writhing on the bed. They might be hypotensive, a bit tachycardic. But when you put your hands on their tummy to examine them, it feels soft. It's not rigid. There is no guarding yet.
That disconnects severe pain, soft abdomen is the hallmark. Why is it soft if the bowel is dying?
Because the ischemia starts from the inside out. The mucosa, the lining, has the highest metabolic rate, so it dies first. But the outer muscular wall, the serosa, is still intact for a while.
So no inflammation on the outside yet?
Exactly. You don't get peritonitis and rigidity until the wall dies completely and perforates.
So if you wait for the rigid abdomen, you've waited too long.
You've waited far too long. By then, the bowel is dead. You need to catch it in that soft but painful phase.
The source distinguishes between an embolus and thrombosis as causes.
Yes. An SMA superior mesenteric artery embolus usually comes from the heart. So you think of a patient with atrial fibrillation or a recent heart attack, a clot flies off the heart and lodges in the artery. It's sudden, like a lightning strike.
And thrombosis.
Thrombosis is usually a gradual clogging due to atherosclerosis, like a plaque rupturing in a coronary artery, but in the gut. Often these patients have a history of vascular disease elsewhere.
And there is a chronic version of this too, right? It's not always a sudden catastrophe.
Yes, chronic mesenteric ischemia. We call it mesenteric angina.
Angina of the gut. That's a powerful image.
It works perfectly. If you have cardiac angina, you get chest pain when you run because the heart needs more oxygen.
Right.
In mesenteric angina, you get tummy pain when you eat.
Because digestion is a workout for the gut. It demands more blood flow.
It demands a huge amount of blood flow.
Yeah.
When you eat, the gut demands high blood flow to do its job of digestion and absorption. If the vessels are narrowed by atherosclerosis, they can't supply it. So 30 to 60 minutes after eating, the patient gets severe cramping pain.
Which leads to the classic symptom of fear of food.
Exactly. The patient is hungry, they have an appetite, but they are terrified to eat because they know the pain is coming. So they stop eating. They lose massive amounts of weight. It's a very sad, very distinct clinical picture.
Chilling. Now, section 6, let's talk plumbing, stomas, and fistulae.
Okay, this is practical, hands-on surgery. We have 2 main types of stoma, an ileostomy and a colostomy.
To the layperson, they might look similar, a bag on the tummy, but to a surgeon, they are totally different beasts.
Totally different. An ileostomy is usually in the right iliac fossa. It outputs liquid, and crucially, it is spouted.
Spouted.
It sticks out like a little chimney, about 2-3 centimeters.
Okay. A colostomy is usually on the left. It outputs solid stuff, and it is flush with the skin.
Correct.
Why the difference? Why do we have to spout the ileostomy?
It's all about chemistry. The output from the ileum, the effluent, is full of proteolytic enzymes. It is active digestive juice.
Ah.
If that fluid sits on your skin, It will digest your skin. It causes terrible excoriation and chemical burns.
So the spout is a mechanical solution. It's designed to throw the toxic fluid clear of the skin and directly into the bag.
Exactly. Whereas colostomy output is just poop. It's dirty, yes, but the enzymes are mostly deactivated by the time it gets there. It's not chemically corrosive in the same way, so the stoma can be flushed with the skin without causing major issues.
That makes perfect sense. Now let's talk about when the plumbing fails spectacularly. Enterocutaneous fistula.
This is a connection between the gut and the skin that shouldn't be there. And the most common cause, by far, is surgery, an accidental injury, or a leak from a connection, an anastomosis.
So bowel content is leaking out through the surgical wound.
Yes, and it is a catastrophe. The patient becomes septic, they lose huge amounts of fluids and electrolytes, they become profoundly malnourished.
The instinct, especially for a junior surgeon, might be to rush them back to theater and just try and sew the hole shut.
And Baily and Love warns explicitly that is doomed to failure.
Doomed to failure. Those are strong words. Why?
Because the patient is in a catabolic state. They're septic, malnourished. The tissues are inflamed and friable. They're like wet blotting paper. If you try to sew them, the stitches will just tear out. You will make the hole bigger.
So you have to wait. You have to resist that urge to operate.
You have to wait. We use the SNAP protocol as a framework for management.
Let's break that down. SNAP.
S is for sepsis. First and foremost, you must drain any abscesses and control the infection. You cannot heal in a pool of pus. You also have to protect the skin from the effluent.
Okay. Sepsis. N.
N is for nutrition. This is absolutely vital. You have to feed the patient, often with TPN, total parenteral nutrition, through a vein because the gut might not be working. You have to build them up, get them anabolic.
Phase 4.
A is for anatomy. You need to map it. Use contrast studies like a CT or a fistulogram. Where is the leak coming from? Is it high output or low output? Is there an obstruction downstream that's forcing things out the side?
Right. And finally, P.
P is for plan.
And the plan is usually surgery, but not yet.
The plan is often to wait weeks or even months until the patient is strong, well-nourished, and the inflammation is completely settled down. Then, and only then, do you go in for a definitive operation. It takes immense patience from both the surgeon and the patient.
Finally, Section 7, malabsorption and intestinal failure. We have to talk about celiac disease briefly.
Right. A sensitivity to gluten causing villus atrophy. The villi, those little fingers that absorb nutrients in the small bowel, flatten out completely.
Diagnosis is by duodenal biopsy. But there is a huge trap here that catches people out all the time.
A huge trap. If a patient thinks they might have celiac disease, they often, quite reasonably, stop eating gluten before they see the doctor. They go on a diet.
And if you biopsy them then, after they've been gluten-free for a few weeks,
the gut might have healed. The villi can grow back remarkably quickly. You get a false negative result. You tell them they're fine, but they aren't.
So the advice is keep eating the bread until after the test.
Exactly. You must be on a gluten-containing diet for the diagnosis to be accurate. It's a critical piece of advice.
And lastly, short bowel syndrome. How short is short?
It varies, but usually if you have less than 200 centimeters of small bowel remaining, you were in the danger zone for short bowel syndrome.
And this leads to intestinal failure, where you can't maintain your own fluids or nutrients without IV support.
Correct. But the unsung hero here, surprisingly, is the colon.
The colon? I thought we were talking about the small bowel.
We are. But if a patient has a massive small bowel resection, their outcome is much, much better if they still have their colon connected.
Why is that?
A couple of reasons. The colon can adapt. It slows down the transit time of food, giving the remaining small bowel more time to do its work.
Okay.
And the colon itself can absorb a huge amount of fluid and electrolytes, and even some calories in the form of short-chain fatty acids. It acts as a crucial safety net.
So in a massive resection, save the colon if you possibly can.
Absolutely. It makes a world of difference to the patient's quality of life.
Which brings us to the end of the chapter. Let's do a rapid-fire outro. The final exam. I'll throw the concept. You give me the detail.
I'm ready.
Anchor 1. Where are the Peyer's patches located?
The ileum.
Anchor 2. Rule of twos for Meckel's. Give me the 2 ectopic tissues.
Gastric and pancreatic.
Anchor 3. Management of a fistula. What's the acronym?
SNAP. Sepsis, Nutrition, Anatomy, Plan.
And Anchor 4. Pain out of proportion to physical signs. What is the diagnosis you must consider?
Acute mesenteric ischemia.
You passed. Now, a provocative thought to leave our listeners with. The source mentions that small bowel transplants are improving over 80% 5-year survival in some centers. But it also talks about new drugs, glucagon-like peptide 2 agonists, things like teduglutide that help the remaining bowel grow and adapt.
It's a really exciting area. So here's the question. With the rise of these biological adaptation drugs, will we eventually make the scalpel obsolete for short gut syndrome?
You mean, can we grow the bowel back?
Or at least improve its function so much that a patient with a very short gut can still eat normally? Will we reach a point where we can just chemically regrow the bowel function instead of transplanting a whole new organ?
A fascinating possibility. The intersection of pharmacology and surgery, something to mull over. Listener, thank you for diving deep with us. Your homework tonight. Open Baily and Love, Chapter 74. Read the fine print.
You interpret, you understand, you remember.
See you next time.